Hello, everyone, and welcome to the CoROM podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric O'Kelly. This week, we are with Rae Richburg, who is a nurse from the United States, and she spent 3 months in Malta taking a load of our CoROM courses. Rae, welcome to the program.
Thank you so much. Hello, everybody. Thank you for having me.
So tell us about yourself and what keeps you busy.
Okay. Well, like you said, I'm a registered nurse. These days, I'm specializing in psychiatric, mental health, behavioral health. And a 72-hour week is not uncommon for me to work. I like to kind of rotate around. So that means to me, I work with nursing agencies and I do contract work. So it kind of helps break up the routine a little bit. So I've had contracts in prisons where I've been assigned to the psychiatric unit. I've been assigned to different psychiatric hospitals, state hospitals, which some of them you can say are prisons that are hospitals or hospitals that have been turned to prisons. I don't really know what the answer to that is, but yeah. So basically, we call that forensic nursing for the psychiatric, which means they are patients that in some cases are criminals. They're criminal minds. They've committed a crime, but they were guilty, but by reason of insanity, so now they're serving their sentence in like prisons where we can give them some medication to help control voices, control voices and things that might be hearing and stuff like that. So I've had a little experience of that. And then most recently I was assigned to a psychiatric unit for adolescents. And that's a whole nother ballgame. Yeah, I don't even know how to explain that one. That was very challenging, but I find it very interesting because mental health can affect anybody, at any time. And it's in different ways. The mind is so complex and we don't really understand it. There's so much we don't know about the human mind, but we do what we can to help somebody become functional, and then maybe they can go back out to be productive members of society. And I do get fulfillment out of that when we can help somebody do that.
That is an amazing experience, isn't it? Having someone come in who has issues and you've been able to help them and make them better.
Yes. The one that comes to my mind, there was a doctor who basically he had his own practice. And I didn't work with him myself, but you could look up his practice on Google. He was a family practice doctor, but he had been doing this for years, and he just got so stressed out. His a PA, his physician's assistant, quit on him, and then he was trying to do everything himself, and all the stress sent him into a psychosis, and so he ended up being our patient,
Wow.
hospital. And we have this doctor who's our patient now, and you could tell he was confused. We're trying to get him back down to baseline so that he could function and speak cognitively, and he's coming behind the nurse's station trying to look at the charts, and we were like, no, doc, you're a patient, you got to go back out. So then he was walking up and down the hall singing and stuff like that. So yeah, mental health can affect everybody. But once we got him on a good regimen of medications where he was cognitive and lucid again, then he got discharged. And I don't really know what happened to him after that, but that was one of the experiences that impacted me as a psychiatric nurse.
So what is your day-to-day like at your work?
The day-to-day. Okay, well, I'm a night nurse. I prefer nights. So basically, when I come in, I try to assess all my patients and see how they're feeling, how their day went. Are they hearing voices? Are they feeling aggressive? Are they feeling homicidal? The problem is I have to do night meds, so I'm kind of under the gun, and I have to get all my meds out by a certain time. Otherwise, it's late, and then it's a med error, which makes assessing the patients like I want to a bit of a challenge. But yeah, I have all these medications I'm supposed to administer in a timely fashion, and then help everybody get to bed, and make sure they feel safe, that they're secure, that they're taken care of. That's pretty much it. And then for the rest of the night, it's a whole bunch of paperwork and audits and stuff. What makes it challenging is we call them codes, CODE, code. So like in a hospital, regular hospital, you got code, white, code blue. These are medical codes for us, but we call them code gray in the psychiatric wards where I've been working, which means we have patients that for some reason they've gone into a psychosis, and they might become violent towards themselves, towards others. They're banging their head against their wall, cutting themselves. We've had patients that have tried to hang themselves.
Wow.
Yeah, we call it code gray, and then we've got to have a whole bunch of staff come in, and we're trying to calm the patient down by talking them down, helping them, just give them a quiet space. Maybe they can talk and tell us what's on their mind. But if we can't do that, if we need to restrain the patient, put some straps on them, that's another that's another story. So nobody likes to do that. But then it becomes more complicated, because when we're using mechanical restraints, we strap them down, and we're using chemical restraints, meaning medications, or we put our hands on the patient to hold them, all that, it becomes legal issue, like really quick. So we have to follow a certain protocol. If we have the patient strapped down, we got to check on them every 15 minutes. Are you breathing? Check their straps so they're not too tight. And as soon as they're able to maintain control, we have to let them out. We can't just keep them in straps. And that can become tricky when you're dealing with like a whole bunch of other patients, who are also having issues. So it's not my best night when I've had like three or four codes going on at the same time.
Wow.
And one patient will set off another patient, so if one is going to psychosis, some of them like to pull off their clothes and run around the ward naked. And it's like, no, put your clothes back on, sir, please. And this other one's banging their head, this other one is faking a seizure, but you have to treat everyone with dignity. It can be mentally and emotionally exhausting. So that's
Indeed.
Is why I like to kind of rotate, go from one facility to another, kind of just get a different angle. If I'm going to the same place over and over and over again, it kind of works on me too. Yeah.
Yeah, it sounds definitely challenging.
Yeah, it can be, very much so.
So what is your interest in remote and austere medicine? Why did you come to Malta for 3 months?
I know, right? Malta. Yeah, I had to find that place on the map. I was like, Malta, okay. But I'll try to be brief. I have kind of a two-pronged reason, two reasons. First of all, I had the opportunity to go to Africa. I was out in Zimbabwe in the year 2014, and then in South Africa in 2019. And I went there as a voluntary Bible instructor. So I was there to support a Bible education program of one of the local congregations. But while I was doing that, as a nurse, because that's my profession, I was also able to recognize different health issues going on in the community. And that moved me to kind of offer some assistance where I could. So, one of these, the first thing that comes to mind is a child that I recognized as malnourished, like really quick. I was like, he doesn't look right. So then after we gave our Bible message, I came back to visit the mother, and I said, what can you tell me what the child is eating or what he's not eating? And in my country, I'm a nurse. So maybe if you want, maybe I can help you a little bit so that they can eat better. So she gave me a history, and then I went to town, which was like an hour and 45-minute walk for me from where I was. And I picked up some formula. Then I brought it back to her, and I told her how to prepare it. And she started feeding her baby, and sure enough, it started looking better, So that was very fulfilling. That was just one incident. But you know what happens when one person finds out you're a nurse, right? Do you want to guess?
Yeah, you had a long queue waiting for you.
Yeah, so well, I didn't have a long line of people waiting for me, but people started finding out I'm a nurse, so they started like some of them would bring me bring me their babies, and they're like, "My sister, what is happening? I don't know. Look at this rash that my baby has. What must I do?" And I'm looking at it like, I don't even know. I never even seen this kind of rash before. There was one rash I remember. It was on the back of like a 3-year-old, and the father pulled up the shirt, and there was this huge, I mean, I don't even know how to explain it to you. If it was like an alien from outer space that attached itself. I mean, I couldn't figure out if it was a fungus, if it was a parasite. I did not know what I was looking at, and I mean that scared me. So they went to the doctor, they got some cream, and it started decreasing in size. And I was like, wow, well, I'm glad they're getting some help, because I felt helpless then. But actually, that did happen a few times when they brought me a rash or some kind of, illness. And so I would take a picture of it, and then I would walk to the pharmacy and say, I don't know what this is. Do you know what this is? Is there something I can buy over the counter to help? So I was able to help in that way. But just being, um, feeling inept, yeah, I went to nursing school, but there's a lot I don't know. Wow. And that made me realize, okay, I need some more training. I don't even know what I'm looking at some of these times. And then if there's an emergency situation, what do we do? I went to one of the hospitals. It was government run hospital. And like, how do I explain to you the situation that I saw? It would be illegal in my country, this kind of
Hmm.
hospital. I mean, they'd
I've
shut it down.
I've been in those hospitals. I know precisely what you're talking about.
Okay. I mean, the smell when I walked in there, and then I wanted to wash my hands because I was like, wow. And when I went to the sink to wash my hands, there was vomit all over the sink, so I was like, I got to get out of here. But the resources are not there. Then we're dealing with a population, or I was, where people are living off of less than $2 a day. So one child, for example, he all he needed was eardrops, which to me was, $5, $10, but that family would never get it because they can't afford it.
Mm.
And so, I mean, I can't just buy medicine for everybody, but if I can get some eardrops, I'll do it, especially in children. If you don't treat ear infections, they can go deaf. So there were times where I was spending money out of my own pocket, but it was okay because I wanted to, and it was appreciated. But I recognized, I need more training so I can recognize what I'm looking at. Also, I'm no good as far as emergencies are concerned, emergency medicine. So this is what I first recognized. I need more. I need some more training. And so I was there in South Africa about 2.5 years. I was there during COVID. Uh,
Wow.
so once the borders opened back up, because the borders had been closed for some time, it was like nobody in, nobody out.
Really.
So once they opened back up, then I got a ticket. I came back to the States. So that was my first reason for looking for, training. For I was looking for something not in a hospital, but training to how to help with medical issues out in the boondocks somewhere. Okay. Then when I came to the States, um, see, before that, I had been like a pediatric nurse, and I worked in gerontology a bit, and I also worked in hospice a bit. Do you understand the term hospice?
Yes. Why don't you explain it though for the readers?
Okay, so hospice, from where I was standing, was you have terminally ill patients, and basically, I mean, there's more than one position when you're working in hospice, but my job was when the patient is like has days to live, like 3, 4 days left, and I was there, basically as support, make sure the patient was comfortable. If I noticed any signs of pain, if they're gurgling, we call it the death rattle, then I would uh, give them some atropine or something to help dry it up so they're not making that noise. And then I was trying to support the family and explain to them what's happening. And I would tell them, the patient can still hear you. The hearing is the last thing to go. So if you want to talk to them, they can still hear you. And then, yeah, if they passed, then I would tell the patient's family, okay, I think they took their last breath now. So I think it's time to say goodbye, and also to call the nurse. There's another nurse that would come and pronounce the patient as deceased. That wasn't my job. I was more support. So I had been doing that kind of thing before, and then I had gone to Africa and I was doing some freelancing nursing on the side. But when I came back to the States at the end of 2021, I ended up getting a job in a prison, of all places. I'm not sure why. Maybe they were desperate. They're like, "You're a nurse, you're hired." So, but anyway, I mean, I took the job. I was so happy to have a job because I had exhausted my funds, in Africa. And so, but right away, I saw that I was inept. And so I was inept, meaning, okay, what scared me the most was if there's an emergency, like a patient is found unresponsive or something like that, prisoner. What do I do? So they had this, we call it a man down box, which is this huge first aid kit, but it's heavy and you're supposed to roll it around. And to me, it was not practical. First of all, it was too heavy. Then you're supposed to respond to the code, or in the prison system, at least the one I was in, we call it ICS, which means Incident Command System. So they'll announce on the radio where I'm declaring an ICS. I need medical support. I need it now. I'm in Ward 1. Please come, something like that. When you hear that call, you have to respond within 3 minutes. Okay. Well, the patient yard, the prison yard where I was working, I think we had like 500 patients. Okay. We had like 5 different wards. To get from one ward to the other, you have to walk across the yard. Then you're carrying all these keys. You got to open this gate. Then you have to use this key to open this other gate. Then you have to go through metal doors, and
Wow.
if the control officer is watching the camera, he'll see you at the door and open it. But other than that, you got to keep ringing the buzzer and hope they open it. And you're carrying this I don't even know what to call it, a treasure chest of medication stuff. So anyway, I had been worried about that because I hadn't really been through an emergency situation. I had taken ACLS and PALS before, but like if you don't use it every day, you know what I mean? It's like, yeah, I passed it, I know it, but I forgot. What am I supposed to do? So I had written an email to my managers and said, okay, I need some training on how to respond to emergencies because it's been a while. And also, I don't know what's in this man down box. So can we open it and I can look at all the medications and make sure I know how to use them and this and that. And I sent 2 emails and nobody responded. And I was getting angry because I was like, well, what if I have to respond? I'm not going to know what to do. Yes, I was working with other nurses, but to be honest, they weren't really helpful. And it was like every man for himself at that situation. So on this one occasion, we had an ICS with a control officer announced on the radio, ICS, I need medical assistance. There's a man unresponsive in the bathroom around Alpha Ward. I need assistance now. So I was like, okay, I got to go. I can't even take that box. It's too heavy. I hope another nurse will bring it. I get there. Sure enough, patient is in the bathroom, passed out. And I said, I can't assess him from here. Can you guys move him? So the control officers picked him up out of the bathroom, laid him outside. I could see he was breathing. But the truth is, I didn't know what I was looking at. Okay. I hadn't seen this prisoner before. I didn't know if he had, diabetes. Was this a diabetic issue? Was this a seizure activity? Was he in the post-ictal stage? I didn't know what I was looking at. And so then I start panicking. And then there were some officers. They were like, yeah, let's start compressions. Let's do compressions. Should we help you with compressions? I'm like, no, he's breathing. He's got a heartbeat. Okay. He's not breathing regularly, but let's not do compression. Yeah, let's do. Should we start compressions? No, not now. And so I'm on the radio and I said, this is Nurse Rae. I need some help right now. I'm outside Alpha Ward. I got a man down. I need some help. Nurses aren't coming. Then another officer's like, okay, should we administer Narcan? And I'm like, you know what? The truth is I've never administered before. I don't know if we should or what I'm looking at, or if it's going to do damage, if if it's contraindicated. So I'm back on the radio. This is Nurse Rae. I need some help. Okay, they didn't come. So then I looked at the chief and I said, Chief, just call 911 because, I'm not really an emergency nurse. I don't know what I'm looking at. I'm not sure what to do. They called 911. The ambulance came. Okay, and I was like, oh, thank you. So they came, and then finally the 5 other nurses, well, it was 3 other nurses show up. We were 5 that night, but I couldn't get any help. Basically, to make a long story short, they administered Narcan. He came back around. They took him to the ER, and then they sent him back after they stabilized him. He went back to his cell. But that whole situation scared me a lot.
No doubt.
Point that I wrote a complaint because I said I had asked for help. I had asked for training. Nobody helped me. Then the other nurses were supposed to be helping each other. Everybody's off doing their own thing, not responding to the radio. And if this man had died, I would have just been the tethered goat, somebody to blame. And I can't get any help. Well, that's not fair for me. And it's not fair for the patient either. Seriously. So I was angry about that. And
No doubt.
yeah. So I just said to myself, let me just go ahead and finish my contract here, and then I'm leaving. And so in that time, then I was like, okay, I need some training. And if I can't get it from my managers, the people who are supposed to be helping me do my job, then I got to look elsewhere. So I started back online trying to find classes for help medical care, like in the boondocks somewhere, and then how to respond to emergencies at the same time. And I came across this term, wilderness medicine, which I hadn't come across before. And I was like, yeah, that seems like something what I need. Wilderness medicine. Yeah, that's it. And so I kept digging into that, and I found Knowles, National
Nice.
Outdoor Leadership School. Do you know about Knowles?
They are the largest provider of the wilderness first aid. They do about 70,000 2-day WUFA courses in the U.S. each year.
Yes, they are completely awesome people. That's all I have to say about that. So when I saw that, I saw a WEMT course, which stands for Wilderness Emergency Medical Technician.
Yep.
And it was a 4-week course. And I said, I'm signing up. That's what I need. So I signed up for that. I saved my money and went to take a 4-week course for emergency medicine in Lander, Wyoming.
It's a nice place. I've been there.
Yeah, it was off the chain. Like, I loved it. I loved it. So when I got there, I didn't tell anybody I was a nurse because
Wise choice.
yeah, I didn't tell anybody because, well, I wanted to come in not as somebody who knew everything, but somebody who was starting at the bottom like everybody else. And yeah, let's all just start on the same page. And they were introducing stuff I didn't know. So when it came to the anatomy and physiology, okay, I could understand that and I could follow that. But then when it came to the trauma assessment, now see, that was something new. And you would think that it's obvious, airway, breathing, circulation. Okay, but like if you're not doing it every day, because in psychiatric field, we have different assessments, because we're assessing behavior, we're assessing the mind status. Okay, so the medical stuff, it just freaks me out. So that was the first time I was introduced to, an order of operations as far as trauma assessment and the stop and fix mentality. Once you're assessing somebody, start with a priority. If you see a problem with that priority, stop it, fix it, then stabilize. So that's what I needed. It introduced me into the order of operations, a methodology of treating somebody in emergency. So I appreciated that so much. The problem for me was when it came down to the written tests, like I was failing all of them.
Wow.
And I couldn't get it because I was like, I'm a nurse. I know this. Why am I failing? And so I finally realized that I was answering the questions as a nurse and I had to answer them as an EMT. So, for example, there was this question about, I don't know, it was a diabetic episode. And I'm thinking to myself, take his blood glucose level and give him some insulin. It's the biggest no-brainer in the history of mankind, But as an EMT, you don't do that. So the answer was more like, give him oxygen and transport. So I was getting all those questions wrong. But then when I finally realized how to answer the questions, I was able to pass, you know, and I did appreciate everything I learned there, especially it being wilderness, because I had in mind going back to Africa where we, you got to use what you've got. You're not going to have everything you want or the supplies you need. You got to make stuff up. But then I said, I need something along the same level as the nurse, that I can give medications, that I can, it kind of sounds like a paramedic. And I
Hmm.
hadn't considered that before. So now I'm back online and I'm like, can I do outdoor paramedic, wilderness paramedic? Is there something along those lines? And then I found RN to paramedic crossover course.
Nice.
So I was back on the computer, back and forth, talking to the administrator of that. And at the end of the day, they said, well, we recognize that you're an RN, but we prefer you to have experience in the working in the ER or in the ICU in order to qualify for this program. So I didn't have experience with that. And so I was a bit discouraged. And so I was like, well, let me see if I can get a job in the ER. And that ended up being unsuccessful for me because, I mean, even at the hospital that I was at recently, I mean, I was asking for a transfer for all practical purposes from the psych unit to the ER. And they said no. But then they're hiring new grads, people who have just graduated from nursing school. And I was like, wait a minute, why are you hiring this new grad when you've got a nurse right here? I already know, the system. I know the charting. I just need, some training. So one of my colleagues told me, they said, it's because they don't want to pay you. See, a new grad, they don't have to pay, but they'll have to pay.
Oh, that's rubbish.
And then they don't want to train you and have to pay you at the same time. So they're not going to give you a job. So I was like, okay, plan D. Am I on A, B, C, D now? So I was like, worldwide wilderness medicine training. Somehow I put that in there. I found Malta, remote medical training offshore. And I was like, wait a minute, what's this? And where is Malta, by the way?
Mm.
So yeah, I started emailing and I had all these questions. I think it was Eric who got my first email. Because when I read about CoROM, it sounded like military medicine. And I'm like, I'm not a combat nurse. I'm not going to be a combat nurse. I mean, do you guys have drills or training with guns or anything like that? I'm not doing it. And and he's like, no. And then I told him, I'm a nurse. Is there any prerequisites? Can I just take the courses for skills? And everything was a green light. So I signed up for all of them. I was like, I need all the courses, all of them. I'm going. And so it's about 6 weeks of, classroom. I think I took 6 courses. And I couldn't get the 6 weeks off for my job, so I gave them a 2 weeks notice. I was like,
Wow.
yeah, I quit, so I could come out here and take that. So this is how I end up in CoROM. I'm
And,
sorry about, my life story being so long, but that's
it's,
what I've got.
and you're still in Malta right now.
I'm actually in Italy.
Oh, you're in Italy. So you haven't left Europe at all.
No, Europe is awesome. I'm just having too much fun. I already quit my job, so it's not like I have to go back to anything.
Yeah.
But my 90 days are rapidly approaching their end now.
Yeah. Well, there's a lot of people that will pop over to a non-EU country and stay for a bit and then come back for so I think you can do 2 90-day stints in a year.
Yes, I think you're right. But I had read somewhere that there's got to be like a 6 months gap or something.
Ah, all right. Fair enough.
Yeah, I don't know, but at the end of the day, I need to go back and start working. My
Yeah.
funds are
So what courses did you take in Malta?
Okay, so the first one was the REMT, which is emergency medical technician, and it was very similar to the wilderness emergency medical technician, but there were some differences. And anyway, I kind of had to start over, just start from the beginning. Let me just learn it the way I'm being taught instead of, well, we did it this way. But
Right.
this time, if I can say, it was clearer, because I knew I had an idea of what I needed to learn and why I needed to learn it. So that was, I think it was 6 days.
Right. And what was the difference you saw between the Knowles WEMT and the CoROM remote EMT?
Great. Okay. All right. The first thing that came to my mind was the practical exam. I had to do it by myself, whereas an EMT, WIMT, we had partners. So yeah, that's the first thing that came to my mind. I was like, oh, I got to do it myself.
Do you know why we do that?
I don't know why, but I do appreciate it.
Because a lot of our graduates are working solo. They are at a remote clinic, or they're working out of an SUV in Iraq or someplace, and it's just themselves.
Well, that makes sense, and yeah, it was valuable training. I won't lie to you about that. So
I would guess that you had a good experience, or you had the experience you had, because you had done 4 weeks of REMT, or the WEMT at Knowles. So you had that as a base to build on.
yes, that's right, a base to build on. Yes. And a lot of it was a review. I think they talked the order of operations a little bit differently, but still, airway open, rate and effort of breathing, circulation, that kind of thing. And the other thing with the REMT was that we had live casualties that we were in our scenarios for practice.
Yes.
So that element was actually very practical, very valuable to me.
And they were pretty red, weren't they? They were spurting and
Exactly.
Yeah,
they were. And I do want to say something about that, because in the psych ward in the prison where I worked, the prisoners, they like to cut themselves like on purpose and cause a catastrophic bleeding so that they can get sent to the hospital. And it's
wow.
an excursion to them. It's a game. So the first time I came face to face with that, it was an inmate. He had cut himself with what? We don't know. I mean, we tried to keep everything sharp away from him, but they were getting it anyway. So he cut his antecubitus artery there, and it was or the vessel there, and it was squirting blood. And he had put it through there's a little box or a little hole where they can stick their hand through, or you want to give them their medication so that you don't have to open the door. Do you know what I'm talking about? Okay, so he cut himself, and then he stuck his arm through that box, that window, so that we could all see this blood squirting. And
Wow.
so they called this ICS. We need medical. We got serious injury here. So I'm running, and all of a sudden I see this fountain of blood, and I froze because it's not something I see every day. And like I said, I'm a psych nurse. I'm not a medical nurse. So I'm like seeing all this blood. I'm like, okay, well, give me your arm so I can, compress it. So then he pulls his arm back to the other side where we couldn't get him. And he's like, So we're looking at each other like, oh, he wants us to go in there. No, I'm not going in there.
Wow.
We need some backup. So we call the officers with their, pepper spray or whatever, and so open the door, finally got a hold of him, restrained him so we could compress the bleed there. But it was blood everywhere, and he was laughing. Okay, he knew exactly what he was doing. And I just told the CO, the control officer, I said, there's nothing I can do. I can't stitch him. That's not my scope of practice. So call 911. Let's get him out. And that's what he wanted. But the point I was trying to make is when I saw the blood, I froze. Okay. So, the panic set in, and like, I didn't like my reaction to the emergency. So when I come to CoROM and you've got these live scenarios with these human actors, and they're squirting blood, the first time I did have the same reaction. I was like, he's bleeding. Look at all this blood everywhere. And then I remembered, wait a minute, this is training. Okay. He's not going to die. At least he shouldn't. And just go through your steps and, stop and fix as you go. So it really was valuable to have the live actors there for us. Seriously.
So that was the difference between the CoROM remote EMT and the Knowles WEMT.
Yes. They did have scenarios, and we did have scenarios where other students were acting like the casualties. Like, oh, I can't move my arm, but the the visual, wasn't there, So at CoROM, you really did put a lot of effort into the visual, the screaming, the makeup, the
Yeah.
guts spilling everywhere, and
We call that a training scar. If we train you to treat your friends, then you're never going to get that oh crap feeling that you got.
oh yeah,
And what's important in a training context is for you to address that wall, that boundary you have, and then in a good and safe environment, walk through that and be able to deal with a live spurting casualty in the future, because you've had this almost real experience that you've been able to deal with and put into a compartment in your head so
mm,
you can act accordingly the next time.
yes, absolutely, and you hit it right on the nail. You hit it bang on. So thank you for that. So the next time when I'm at the hospital, and I can work through it better than before. Absolutely. So thank you,
Yeah.
CoROM, for that. That's well done.
So after the REMS, what did you do?
Okay, after the REMT was APIS ultrasound. Wasn't
Austere and pre-hospital ultrasound.
Yeah, that.
Good.
Actually, I do take away that ultrasound training as one of the most valuable, if not the most valuable skill, because I've had ultrasounds before done, but when I'm sitting there laying on the table and they've got this probe going on and I'm looking at their screen and I'm like, I don't know what they're looking at. And then they're like, take a big breath for me, hold your breath. And they're taking pictures, but reality, I don't know what they're doing. I don't know what they're looking at. So this was my first time with an ultrasound machine myself. There was that butterfly that we used, right?
Yep.
And there was that tricorder looking thing. I never can remember the name of it.
It's a V scan.
Yeah, that. And trying to learn the anatomical marks so that you can get the image that you want, so that you can recognize free fluid in this space that you're looking at. And so that was completely new for me, very valuable. And I mean, I'm convinced I want to get one of those myself, because I'm saying the butterfly or the V scan. I want to get one of those myself because when I was in South Africa, the women over there, they were getting pregnant like a lot.
Yeah.
And well, see, that's another class I would have to take for myself, is because we did the EFAST, where we're learning how to recognize free fluid in the pericardial and peritoneal spaces. But I'd be interested in being able to see the baby, is the baby positioned right, something like that. I don't want to go back to school for ultrasound, but just to have a general knowledge, and that way I can say, you know what, the baby doesn't look right, or it's not positioned correctly. I think we need to go to the doctor. I mean, just that would be very helpful to a lot
Yeah.
of.
Unfortunately, we are limited at doing that. It's an ethical problem, because if we bring in a pregnant actor
Right.
and we do an ultrasound, and then the next day she aborts,
Oh no.
she's going, yeah. So getting a course to teach ultrasound on actual pregnant people is difficult. It's an ethical challenge and a moral challenge, and then um, try to get this in an environment where the women are educated enough to know that the ultrasound doesn't actually cause any problems. So that's one of the main reasons why we don't do any type of obstetric ultrasound.
Yeah. No, that does make sense. And you know what I think? If I was pregnant, I wouldn't want people practicing on me either. So that's another thing, right? But I can see where this would be another class that I would have to look for somewhere, or at least.
Oh, they have them, definitely, yeah. But you'll find them in medical schools, I think.
Okay. But
And then you use ultrasound again in the critical care course, the eye care course.
yes. So that time, I care. I think we did it in AEC too, didn't we? At the end.
Oh yeah, the Sean Keenan course, the prolonged field care course. We always throw in ultrasound there as well.
Yes, very valuable, very valuable. And So the more I did it, I think I did it at least 20 times, So the more I did it, the faster I got. I knew what I was looking for. I knew the anatomical marks. I could recognize them. Whereas before CoROM, I couldn't do any of that. So definitely one of the best takeaways from that course. Yes.
Yeah, we do force you to do a lot of repetitions. I've been on courses, the Royal College of Emergency Physicians in the UK, where you're in a class with 60 other people and you touch the ultrasound once, and then they give you a piece of paper. You're grand. I don't learn that way at all.
No, the repetition. There's a saying in Spanish, repetición es la madre de retención, which means, when translated, repetition is the mother of retention.
Nice.
Do you understand that?
Yeah. Nice.
Yeah. So definitely, I appreciate it. And then the class being somewhat small gave all of us a chance to do it, and then the instructors being willing for us to practice on. Like, all of you guys are pulling up your shirts and you're like, no, it's touching it, move it over here, move it over there, because every body is different. You get the general area, but learning how to move the probe, how to wave it, how to fan it, find your anatomical marks again on different bodies, different body types. That was very valuable. Really, thank you for doing that for us.
Good.
I love it.
Well, we have a standard of 4 to 1, so 4 students for 1 instructor.
Okay.
And we found that is the best learning environment.
Yeah, absolutely. Because in this way, but in other way, not only for ultrasound practice and other skills that we were practice, but class discussion. We were able to ask questions, and I hated nursing school, to tell you the truth, because there were too many people in the class, and then I would read the chapter, and then I would come to class and I raise my hand. I'm like, I need clarification on this. What does this mean? What is this? What is that? And it was like I got shot down because I remember my teacher, she kept saying, it's in the book. It's in the book. And I'm like, I know it's in the book, but I didn't understand it. That's why I'm coming to you, asking you. And there's the time constraint and trying to get to everybody. So I understand, but it got so frustrating at one point. I was like, I'm going to the dean of nursing and I'm going to just ask them if I have to come to class, because if I'm not learning anything, why am I here? I can just stay home and study and then YouTube everything else and then show up for clinicals. That would be better than sitting here listening to this lecture. I don't know. I think my mom and dad talked me out of that. But with CoROM, with the class size being small, there was more interchange, more interaction. I was able to get my questions clarified. And also I believe that questions were welcome. I would always preface my question with, yeah, I have a stupid question to ask, or I should know this, but I really don't, because I'm somewhat ashamed. But all the instructors welcomed our questions. They never made us feel, stupid, for a lack of a better phrase. And I appreciated that. It was they were all approachable. They wanted to teach us. They really were passionate about what they're teaching. All of us, all of the instructors, every single one. I could tell they wanted to be there. They really enjoyed and believed in what they were doing. And, having a teacher that's passionate and believes in what he or she is doing, that's a gold mine right there. You can learn anything from that person. So yes.
And that's been the challenge, to get these people in to teach for us, and finding them out in the wild and convincing them to come to a tiny little rock in the middle of the Mediterranean.
Right. Well done with everybody you've got. I love every single one of them, really. Yeah.
So what's next for yourself? What's your 5-year plan?
5-year plan. Okay. Let's see. Besides going back to the US and applying for another job and generating some more funds here, I feel like I need to take some more courses. I'm interested in midwifery, to be a midwife exactly, but to be able to help with childbirth, because at the end of the day, my goal is to go back to South Africa. I was doing the Bible education program there, and I really enjoyed that. That's what I want to do. But I'm also a nurse at the same time. So if I can help people, in more ways than one, that's what I want to do. But when I go back, I need to have, more skills than I had the first time so that I can be more helpful. So the midwifery, what do they call that thing? Doulas.
Yeah, that sounds about right. Yeah.
So I don't want to go back to school for that exactly, but if I can find a course that would help me help be assisting and delivering babies in third world countries, for example, that would be helpful. I'm interested in learning more about the ECGs, EKGs, because I'm weak on that. We did go over, for example, like if we have a patient with a crush injury and we have an ECG available in the remote setting, we can kind of monitor, was it the T wave? If we have a T wave that's elevated, then that means there's hyper.
No pot, no tea. So
Cal-
if there's no potassium, no pot,
okay.
then you have no T wave.
Yes.
So if you have a lot of tea, you have a lot of pot.
Okay. Hyperkalemia.
Yeah, there you go.
Got it. So that's a weak point. My ECGs. And then what else did I want to know? No, midwifery. Yeah, but at the end of the day, I want to be able to go back to Africa to what I was doing, or else help with disaster relief.
Good deal.
Disaster committees. We have so much war going on, and I see it escalating. I don't see it going away. Then there's all these natural disasters, like a few weeks ago, there were like 1,000 tornadoes in my own country, 1,000
Wow.
in one weekend.
Wow.
There's flooding going everywhere. The weather is unpredictable. So being able to help with relief efforts, disasters. Okay. Yeah. Totally want to sign up for that.
Good deal. So, Ray, my final question for you is this. What advice do you have for the new paramedic, the new nurse, new doc, who's interested in working in austere environments?
Sign up for CoROM, seriously.
Well,
Yes, because it's the training, we had already said, it's not a military school, it's for the civilian. So that opens the doors for a lot of us. It helps us to um, develop more skills with like improvised medication. And I would encourage it because the world is changing. It's becoming very, very dangerous. And if you have some skills that will help you stabilize somebody or even save somebody's life, especially at a time when the healthcare system might be on the brink of collapse, which it is in so many places around the world, that would be a game changer for so many reasons, for so many people. So I would encourage it, definitely.
I agree. Yeah, that's good advice. And thank you for taking the time to speak with us today. And it was interesting hour having a chat with you.
Okay, thank you so much.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at corom.edu.mt.